Welcome to the intriguing world of endometrial cancer, the most common gynecological cancer in the developed countries. Its occurrence is on the rise in the developing nations too. It ranks as the sixth most common cancer in women and 15th overall, typically affecting postmenopausal women. In India alone, there are 16,430 new cases and 6,385 lives lost to carcinoma endometrium, according to Global Cancer Observatory 2022 statistics. Today, we delve into this complex condition, seeking awareness and a path towards a brighter cancer-free future with insights from our esteemed guest, Dr. Renuka Gupta, a senior consultant in gynae-oncology at Sri Agdase International Hospital, Delhi. For those who have been with us before, you already know the depth of knowledge and expertise this esteemed speaker brings to our discussion. And for those who are new to our discussion, brace yourself for an enlightening conversation. Hi, I am Dr. Harshita, your host for today's discussion, centered around the topic endometrial cancer. And it's a pleasure to have you back with us, Dr. Renuka.
Hi, Dr. Harshita. It's a pleasure for me also to sit with you and enlighten about this topic, because this is really a great burden in India, in the worldwide, because incidence of endometrium is now increasing because of change of our lifestyle.
Yes, doctor. Thank you. So let's begin our session. So my first question is, with the rise of cases, what are the common risk factors associated with endometrial cancer these days? And how do these factors influence its occurrence and prognosis?
So definitely when we tell about the endometrium, endometrium is a hormone sensitive tumors, as we know. It's a two type of tumors, type 1 and type 2, and type 1 is most common type of cancer in endometrium, which is hormone sensitive. And the most common risk factors are basically the risk factors which increases the unopposed estrogen. So basically the nulliparity is the usually increases the risk. Again, this early menarche, that menarche started at early age, and menopause at late stages, because these usually increases the incidence of anovulatory cycles during at the time of puberty and at the time of perimenopause. So this phase also increases the risk of endometrium. Risk is obesity, because obesity is another risk factor, because it changes the androgen to estrogen in our body. So it again increases the estrogen content in our body rather than the progesterone. Next is PCOD, which is very common nowadays. So rise in incidences mainly because of a PCOD, obesities, and nulliparity. You can see now incidence each and every, if you see in a OPD, every third female is suffering from the PCOD. And in PCOD, there is anovulatory cycle. Because of anovulatory cycles, there is estrogen is in excess without the progesterone. So these are always a risk factor for the endometrium, because estrogen is working, but progesterone, which is having an anti-neoplastic effect, is not working. So that is because of these of the lifestyle changes, we are increasing the risk of PCODs, infertilities. So because of these, incidence is rising. Again, the estrogen hormone replacement therapy is also a risk factor for the endometrium. Previously, it was given estrogen alone as a hormone therapy. Now, tamoxifen given for the hormone sensitive breast cancer patients as a risk reducing hormone therapy. So this tamoxifen also works as an agonist to the endometrium. So it also increases the risk of endometrium. So these are the few risk factors which are basically responsible for the endometrium. And for the current scenario, if you see, it is the lifestyle changes which increases the risk of definitely endometrium.
Yes, Dr. Renuka, and this is a concerning health issue, and understanding its common risk factors is essential for early detection and prevention.
Yeah,
Yeah, so moving ahead, in many studies, doctor, it has been proved that there's a strong association of endometrial cancer with long-term unopposed estrogenic action, either exogenous or endogenous, in women with an intact uterus. So, can you provide your insights on this association?
And definitely, as I told previously, the risk factor is basically the unopposed estrogen only. So basically, what happened? As we all know, are about the menstrual cycle. In menstrual cycle, first estrogen is working as a proliferative phase. Then the progesterone is worked over the estrogenic endometrium, and then it shed as a menstruation. But what happened when progesterone is not available or estrogen is excess? Estrogen is having their proliferative effects without any antagonizing effects of the progesterone. So they keep on changing, and certain mutations and genetic alterations occur because of excessive of estrogen. That usually causes the carcinogenic changes. So each and every study it has been shown that all the risk factor usually predisposes the endometrium towards the excess of estrogen without the progesterone. Even in 1960s, when we have started the HRTs to prevent the osteoporosis for the heart issues. Then they have seen after the use of 10 years of estrogen alone as a HRT, there is increased incidence of endometrium in 1970s. So then we have started a combined form of hormone replacement therapy. So now we are usually not giving estrogen alone as a estrogen therapy, as a hormone replacement therapy in patient with intact uterus, because it increases the risk of endometrium. And even if you see the other risk factor like the nulliparity, early menarche, late menopause, all these factors also causes the increase in a estrogen in anovulatory cycles. So these all are in all studies it has been shown that estrogen without progesterone is the risk factor for the endometrium. So whenever we are using the HRTs nowadays, definitely we'll use either the combined therapy in a continuous manner or in a sequential manner. So it will protect the patient for the skin.
Yes, thank you, Dr. Renuka, for providing your insights on this association. So, can you also discuss the typical symptoms and early warning signs of endometrial cancer that you encounter in your practice?
So, endometrium is usually causes a good prognostic cancers also, just because its symptoms usually appears very early. Uh, Usually, patient in postmenopausal phase, patient came with a postmenopausal bleeding. So, whenever a patient with postmenopausal bleeding came to us, it's only 5% chances that the patient is having a endometrium, but we have to rule out this endometrium part because with the help of biopsy. So we cannot neglect the postmenopausal lady with uh, postmenopausal lady with bleeding. Whenever a patient present, we have to diagnose. So important imaging, important is imaging. With the help of imaging, we can rule out the endometrial thickness, what endometrial thickness is there. So we should take a biopsy or not. So important is postmenopausal bleeding or any menstrual pattern which get disturbed. Like in a perimenopausal ladies, usually because they are having an anovulatory cycles. So in anovulatory cycle, estrogen is there, progesterone is not there. So they also usually having a heavy menstrual bleeding, either in the form of repeated cycles, twice in a month or thrice in a month, or sometimes continuous vaginal bleeding occurring for a month or two. Sometimes they are having a heavy flow during their periods. So these all are can be a warning sign if patient is even usually these are seen in a perimenopausal ladies, but sometimes in today's scenario with a patient of obesity and PCOD, even we can see the endometrium cases in a 30 to 35 years of age. So we have it should be clicked in our mind whenever a obese patient or a patient suffering from PCOD came to us with a change in their bleeding pattern. She is suffering from heavy vaginal bleeding and frequent bleeding or continuous bleeding. We usually take a biopsy just to rule out the endometrial cancer. So endometrial cancer usually present with the bleeding only. Only in a late stages it can be present with a urinary retention, pelvic pain and all, but these are usually later. So CA endometrium bleeding pattern is changed and we can diagnose this very early stage.
Yes, doctor, and recognizing these symptoms and early warning signs is vital for early detection and timely intervention. Yeah. So, doctor, what are the current recommendations regarding endometrial cancer screening and how have they evolved in recent years based on the latest research findings?
If we'll talk about the endometrial screening, it is not as efficient as a cervical screening is there, because for any screening test we need a sensitive test. That test should be specific enough. It should be in a positive predictive value. So in a cervical screening, the cancer program is very much effective because it usually detects, and it is in a superficial cervix is in superficial organ. But for the endometrial cancer to detect, we usually have to do the ultrasounds, either the TPS ultrasound, the TS ultrasound, to see the endometrial thickness. But it is not always that if endometrial thickness is increased, there is cancer. So it causes the unnecessary increased burden of interventions and psychological pressure to the patient. So as present, there is no current screening guidelines for the C endometrium because it is not cost effective. And it usually increases the unnecessary intervention to the patient. But in patient who has having a family history of C endometrium, like Lynch syndrome, if Lynch syndrome is in her family, definitely she is at risk of C endometrium, because if she is positive for Lynch syndrome, she is having a 40 to 60% risk of C endometrium, and C endometrium is be the sentinel event, sentinel cancer, because it increases the colon cancer risk also, it increases the ovarian cancer risk also in a patient with a Lynch syndrome. But C endometrium is usually a sentinel event. So in these patients who is having a history of Lynch syndrome in her family, we usually prescribe screening in these patients 10 years before the index case. So they can undergo the annual screening program, in which we are usually can use either the ultrasound as a screening, but in ultrasound, even in the ultrasound, sometimes it can be a misleading. So annual endometrial biopsy is recommended for these patients to rule out the endometrial cancer in these patients, so that we can offer them the risk-reducing surgeries in these patients.
Yes. Thank you, doctor, for providing your valuable insights. And moving ahead, what are the key diagnostic tests and imaging modalities used in the evaluation of endometrial cancer? And are there any additional tests or evaluation typically performed to confirm the diagnosis of endometrial cancer?
So, as I previously told, that endometrial hyperplasia is the best predictor for the seeing any abnormality in a endometrium patient, which is the patient who needs a biopsy. So first and foremost modality of imaging is transvaginal ultrasound. Whenever a patient with a postmenopausal bleeding or heavy vaginal bleeding or any changes in their menstrual pattern came to us, we usually prescribe a transvaginal ultrasound, which is very sensitive modality. In postmenopausal ladies, if the endometrial thickness is more than 3 millimeter, it gives a signal that you should do something. So in patient where the endometrial thickness is more than 3 millimeter, we advise biopsy. Biopsy can be either through the hysteroscopy guided or a blind biopsy or an office pipple biopsy can be done. Any type of modality we can use in a biopsy. But nowadays, simple diagnostic test, office pipple biopsy, which is there because it doesn't need any anesthesia or any intervention, major intervention, and it is very easy to perform. So in this, we can take out the sample and send for the histopathology, which can predict cancer is there or not. In perimenopausal or in perimenopausal ladies or in young females, if endometrial thickness is more than 12 millimeters, then also it gives like a suspicion that patient is having a continuous vaginal bleeding and her endometrium is more than 12 to 15 millimeters. So it also gives a apprehension about the endometrial hyperplasia, which can be a C endometrium also. So in these patients, definitely we should do some intervention, and in even OBs and PCOD. Who are the patients who are at high risk? we have to do the intervention. Basically, biopsy, endometrial biopsy, with the help of people is sufficient enough to rule out the CA endometrial condition. And once the diagnosis is there, then we can evaluate further the CA endometrium. We can do the imaging to see the spread of the disease in a myometrium or in a pelvis or in metastatic disease. So we can rule out to see the treatment guidelines. Therefore, what we have to perform for the treatment of the patient.
Yeah. So, doctor, how are the different stages of endometrial cancer determined, and what are their respective treatment approaches?
So, in CA endometrium, main treatment approach is surgical. The stage is basically surgical, not the clinical. But whenever patient came to us, we have to evaluate to see the operability of the patient also. Because in CA endometrium, we have to do the surgical staging. Surgical staging can be done completely only after the surgery. For the radical surgery, we are doing for the CA endometrium. Complete staging is done. But initially, we have to evaluate the disease is metastatic or not. If disease is not metastatic, that is not reaches up to the lungs and livers or the vital visceral organs, then we can operate the patient, and we have to see the operability, fitness of the patient for the surgery. So stage 1 is basically disease limited to the endometrium, that is uterus only. And in now recently we have a updated FIGO staging, in which it shows that some low grade tumors are also there, in which ovaries are involved separately. So in new staging, stage 1 includes disease confined to the uterus and ovary in cases of low grade tumors. In stage 2, it goes up to the cervix. According to the previous stage, disease reaching up to the cervix is stage 2, but now they have incorporated certain lesion, that high grade extensive lesion, if involve the endometrium, more than 50% of endometrium is also involved in stage 2. So they have changed the staging recently, and we have to see the prognosis according to the stage, new staging. But according to the old stages, it was that stage 2 is reaching up to the cervix. Stage 3, then disease is up to the uterine serosa or the pelvic peritoneum or the node. That is, disease is outside the uterus but limited into the pelvis only. And stage 4, disease is either in the stage 4, it is in the bowel and bladder, that is because bladder is anteriorly and rectum is posteriorly. So disease in the bladder or in the rectum, this is stage 4A, and 4B spreads to the visceral organs and upper abdomen. So this is the stage 4. And definitely treatment we have to decide according to the disease only, because in stage 1, stage 2 and stage 3 we can do the cytoreductive. Stage 1 we can do only the radical hysterectomy and we can do the node dissection, and according to the stage 1A, 1B, we have to decide the adjuvant treatment according to the grades also. So radiation, patient needs only the radiation or needs the adjuvant chemotherapy, because in stage 1A we can give only the observation also, or in few high risk patients we have to give the vaginal brachytherapy or the EBRT. Stage 1B, we should give EBRT to the patient if patient is at a high grade. We have to keep all the staging in mind whenever we plan the adjuvant treatment. So definitely surgical staging is important for the adjuvant settings also. In stage 2, definitely we have to give radiation therapy if cervix is involved. And in stage 3, as the disease gets spreads, definitely we have to add the chemotherapy. And stage 4, definitely we are starting with chemotherapy. We see the response of chemotherapy as a neoadjuvant chemotherapy. Then we'll operate the patient after seeing the disease control, that is visceral control of the disease, and then we operate the patient for the symptomatic and complete cytoreduction to remove the tumors. So definitely treatment always depends on the spread of the disease, stage of the disease.
Yes, thank you, doctor. This was a very comprehensive explanation. And moving towards our last question, what advancements or breakthrough have been made in targeted therapies for endometrial cancer?
So now if you see, there is a very much importance of immune check inhibitors and immune therapy nowadays. So there is a PD-1 inhibitors and PD-L1 inhibitors that usually having an advancement in the treatment. So as a PD-L1, we have introduced the pembrolizumab, and as a PD-1, we are dorsodimab. So these drugs having a very increase in a response to the therapy. Initially, there is a only we are prescribing carboplatin as a chemotherapy for the advanced disease or for the recurrent disease. Now, addition of these immunotherapy, even in a primary treatment or even in a setting of recurrent disease, advanced recurrent disease, these therapy increases the progression-free survival as well as the overall survival of the patients, so that we can incorporate in with the chemotherapy and or even as a monotherapy to the treatment, so that patient's survival can be increased. So definitely there is a role of these immunotherapy nowadays.
Yes, doctor. Your insights into this evolving landscape of endometrial cancer treatment sheds lights on the ongoing efforts to improve the patient outcomes and enhance overall quality of care. Now, doctor, we have arrived towards the end of the session. And thank you for sharing your insights, and your expertise and insights always elevate our conversation to the new heights.
Thank you, Dr. Ashika. Thank you, MedSynapse, for that opportunity.
And a huge thank you to our audience for tuning in. And before we conclude, I want to bring your attention to the MedSynapse platform, our vibrant hub that's redefining the healthcare landscape. It serves as an invaluable resource for professional doctors like you, offering opportunities to engage in meaningful discussions, connect with expert doctors, and be the part of the advancements in healthcare. So why wait? Explore MedSynapse platform right now to make the most of these remarkable opportunities. Feel free to drop your comments in the section below. If you have any questions, we'll be more than happy to provide you with the answer you seek. Until next time, take care and keep advancing in your medical journey. Goodbye.